All right, let's get right into it. Today, we're taking a deep dive into a true master of adaptation, Enterococcus faecium. This bug has gone from being a pretty quiet member of our gut flora to one of the toughest hospital-acquired pathogens we have to deal with. Now, everything we're about to cover is based on a Gemini deep search of the latest literature and guidelines. And hey, if you really want to get into the weeds, the link to our full-source notebook is right there for you. Okay, so here's the plan for today. We're going to follow this organism's entire story. We'll start with its wild evolutionary journey, then we'll look at the diseases it actually causes and how we nail the identification in the lab. After that, we'll tackle the massive challenge of treatment, and we'll wrap it all up with the thing that matters most, infection control. So first things first, it is absolutely crucial to understand that when we say Enterococcus faecium, we're not just talking about one single bug. We're really talking about two completely different groups or clades, and they play by very different rules. I mean, look at this. It's a story of evolution on hyperspeed. The hospital environment, just flooded with antibiotics like cephalosporins, which Enterococcus faecium is naturally resistant to, basically rolled out the red carpet. It just wiped out all the competition in the patient's gut, which allowed this hospital-associated clade to absolutely explode and vacuum up a whole arsenal of resistance genes. So, how in the world does this super adapted hospital bug actually make people sick? Well, it's not about being some kind of super toxin powerhouse. It's all about being the ultimate opportunist. Let's open up its toolkit and see what it's working with. The list of infections is pretty broad, but you see the theme, right? It hits the most vulnerable people, the hospitalized, the immunocompromised. And that mortality rate for bacteremia, higher than its cousin, Enterococcus faecalis, wow, that's a really stark reminder of just how tricky this thing is to treat once it gets going. And here's the key. Enterococcus faecium doesn't win with brute force. Its whole strategy is about persistence. It's got adhesins like ACM to literally glue itself to collagen on heart valves, ESP to build these rock-solid biofilms on catheters, and then these amazing stress proteins to survive in places like the biliary tract that would kill most other bacteria. It's truly a death by 1,000 cuts. All right, for all of us working on the bench, this is where we come in. Getting a fast, accurate identification isn't just a lab result. It's absolutely fundamental for patient care and for stopping outbreaks. Under the microscope, it's a look we've all seen a million times, right? Classic gram-positive cocci hanging out in pairs and short chains. But you know as well as I do, you can't stop there. It could just as easily be a streptococcus based on morphology alone. On a plate, it's not very picky. But that ability to grow in bile and hydrolyze esculin, turning that agar black, that is the classic old-school presumptive ID that's been a workhorse in labs forever. And you got to admit, on chromogenic agar, those little turquoise blue colonies really pop. Makes life a little easier. And this table, this is where the rubber really meets the road for telling it apart from Enterococcus faecalis. Just look at that carbohydrate pattern. It's a perfect mirror image. Enterococcus faecium ferments arabinose but not sorbitol, while Enterococcus faecalis does the exact opposite. Making that distinction is so important because their typical resistance profiles can be worlds apart. But, of course, technology has totally changed the game. I mean, MALDI-TOUGH mass spec is the standard now, giving us a species ID in, a few minutes? It's incredible. And even better, for that critical information, we can use a PCR to find those VAN A and VAN B resistance genes straight from a patient sample, getting an answer hours, maybe even days before a culture is final. But here's a super interesting twist when it comes to using MALDI-TOUGH for predicting resistance. Turns out, the specific protein peaks that correlate with resistance aren't universal. They call it the regional peak problem. It means an algorithm that was built using European isolates might totally fail if you try to use it on North American ones, just because the dominant clones are different. It's a massive headache and means you have to do so much local validation. Okay, so we've got the ID, now comes the hard part, guiding therapy. And let's be honest, with Enterococcus faecium, it is almost never simple. Getting this right means relying on really solid antimicrobial susceptibility testing and then interpreting those results against standards like the EU CAST breakpoints to figure out the best move. Let's take a look at the Dutch SWAB guidelines for endocarditis because they lay it out so logically. If the bug is amoxicillin resistant, but you can still get that synergistic kick with an aminoglycoside, you go with the combo. Simple. But if you've got high-level aminoglycoside resistance, that synergy is gone, so you drop the gentamicin. And if it's VRE, Vancomycin-Resistant Enterococci, well, then you pick up the phone and call a specialist, because you're in a tough spot. Now, if we zoom out to the international guidelines for VRE, you see that linezolid and daptomycin are the real workhorses for the big, scary systemic infections. But here's the really important takeaway: stewardship, right? For a simple VRE cystitis, we can often use drugs like nitrofurantoin or phosphoricin that just hang out in the urine. That lets us save our big guns, our last-line agents, for the fights where we truly need them. Treating kids, though, that's a whole other level of complexity. There is a serious lack of good pediatric-specific data, so almost everything we do is an educated guess based on adult studies. Take daptomycin. You often need much higher doses per kilogram in kids to get the same effect. Given how high the stakes are, getting a pediatric ID specialist on board isn't just a good idea, it's essential. And that brings us to our last section, which honestly is the most critical of all. Because treatment is so difficult, our absolute best weapon is just preventing the transmission from ever happening in the first place. And this one number, is exactly why prevention is so hard. 4 months. That is how long Enterococcus faecium can just sit there, perfectly viable on a dry hospital surface. Think about that. A bed rail, a keyboard, an IV pole. Its ability to survive in the environment is just incredible, and it's what makes it such a nightmare for infection control. So, because it's such a survivor, strict contact precautions are completely non-negotiable. It means a single room if you can, gown and gloves every single time you go in, and using dedicated equipment for that patient. There's just no room for cutting corners here. But those precautions are just one piece of a much bigger puzzle. You need a whole program built around it. That means a relentless focus on hand hygiene, obsessive environmental cleaning, actively screening high-risk patients to find that hidden reservoir, and smart antimicrobial stewardship to ease up on the very pressure that helps VRE take over. But here's the scary part. Just when we think we've got our strategies locked down, the organism evolves. In the last few years, we've started seeing isolates that are actually tolerant to alcohol-based hand rubs, the single most important tool in our hand hygiene arsenal. This is, well, it's a deeply concerning curveball. Which leaves us all with a pretty unsettling question, doesn't it? As this pathogen keeps evolving to get around our most basic defenses, are the strategies we're using right now really going to be enough to hold the line? I genuinely love to hear what you think about this in the comments. Hey, thank you so much for joining me for this deep dive into Enterococcus faecium. If you found this explainer valuable, please do subscribe to the channel, and of course, share your feedback. We read it all.